Go ahead and get started as people keep joining the room. Thank you so much for joining us today. My name is Emmy Betts, and I am the Deputy Director for the Program for Injury Prevention, Education, and Research at the Colorado School of Public Health and the University of Colorado School of Medicine. Today's Research to Practice webinar is co-sponsored with the Center for Health, Work, and Environment, also at the Colorado School of Public Health. So before I get into introductions for our two guests, I want to do a couple quick housekeeping points. First up, please mark your calendars for 2021 series. We'll be meeting the second Tuesday of each month, starting in January. Our first webinar will be January 12th, focused on hospital-based violence prevention programs. Today's session, like the others, will be recorded, and the link will be posted on our website as well as emailed to all the registrants afterwards. And then we'll be doing some questions and answers at the end. So please, along the way, put your questions into the Q&A box, and we'll be collecting them to ask our speakers afterwards. And so now it gives me great pleasure to introduce our two speakers today. First up will be Dr. Thomas Hales, who is the Senior Medical Epidemiologist with the CDC at NIOSH. He's also a physician board certified in internal medicine and occupational and environmental medicine. In 1999, he helped establish and administer NIOSH's Firefighter Fatality Investigation and Prevention Program, which he's now co-administered over the past 20 years. He serves on the NFPA Technical Committee on Fire Service Occupational Safety and on ACOEM's task group developing guidelines for the medical evaluation of law enforcement officers. He's currently the vice chair of the ACOEM Public Safety Medicine section. He'll be followed then by Dr. Elisa Koval, who we are very lucky to claim here in the Denver area. She is currently the head of the Division of Occupational Medicine at Denver Health, and she is also a physician. She's past president of the Rocky Mountain Academy of Occupational and Environmental Medicine, and she's currently a member of the American College of Occupational and Environmental Medicine House of Delegates. Additionally, she serves on the board of directors for Building Warriors, which is a nonprofit organization dedicated to the mental health of first responders, which we know has been a particularly important topic this year. And so in today's webinar, they'll be focusing on occupational injuries among firefighters, which certainly, given all the wildfires this past fall, has been something that has been on many of our minds. These are individuals who are really tasked with keeping our community safe and yet face incredible hazards along the way. And so I welcome again our two guests today. So I'll turn it over now to Dr. Hales.
Okay. Well, good morning or good afternoon to everyone. Thank you for that introduction. As mentioned, I'm a medical epidemiologist with NIOSH in the Division of Safety Research. And I'm actually physically located in Denver as well, although my home office is based out of West Virginia. I'd like to thank the Injured Program for allowing me to speak today. We'll be talking about firefighters. And for those of us who study occupational health, firefighters present us with a unique challenge. Why a unique challenge? In most workplaces, we strive to eliminate, substitute, or engineer out the job hazards. We start with the most effective controls and move down to those considered least effective. Eliminating or physically removing the hazard is the most efficient, followed by substituting or replacing the hazard with something less hazardous. This is followed by engineering controls, which isolate workers from the hazard, and administrative controls, which change the way people work. And finally, personal protective equipment, or PPE, which is considered the least effective controls. Firefighters, when they are responding to emergencies, cannot control the settings, or for lack of a better term, the workplace. So instead of using elimination, substitution, or engineering controls, we must turn to administrative controls and PPE for protection and prevention. Controls that are lower down on our effectiveness hierarchy. For the next 20 minutes, I'm going to cover the following 4 topics: the magnitude of the problem in terms of both fatal and non-fatal injuries, use descriptive epidemiology to characterize these injuries in the terms of person, place, and time, and use findings from the NIOSH Firefighter program, which is the NIOSH Firefighter Fatality Investigation and Prevention Program. That's a mouthful, so I'm just going to call it the NIOSH Firefighter Program. In this program, we use to drill down on the contributing factors and prevention recommendations. And finally, I'd like to briefly present one of our investigations of a Denver firefighter who lost his job due to an occupational injury. I'm going to be using 8 sources of data for this presentation, and I will include a citation at the end of my talk, which has all the references and links, hyperlinks to these data sources. These 8 data sources, the first will be from the National Fire Protection Association, their Fire Department Profile Survey, which is authored by Ben Efforts. Their annual fatality census, which is led by Rita Fahey, and their annual non-fatal injuries, led by Rich Campbell. Another source will be from the Bureau of Labor Statistics, their C4 data, which is the census of fatality occupational injuries, and then their survey of occupational injuries and illnesses. Been using 2 sources of data that NIOSH has published. The first is from the National Electronic Injury Surveillance System. There's, which we call the NICE work. It's an occupational supplement of the all injuries that are found in the emergency department. And our colleague Suzanne Marsh is the one who led this effort for NIOSH. And finally, the second source from NIOSH is the Firefighter Reports, which is a case series analysis led by another one of my colleagues, David Hart. And finally, I'll be using the US Fire Administration data source called NFIRS, National Fire Incident Reporting System, from the years 2015 to 17. And this data source specifically looked at fireground injuries or injuries that occurred while fighting fires. You're probably asking, why am I using 8 data sets to describe the problem? And it's not meant to confuse you, but rather to point out that each data source has its strengths and its weaknesses. And these strengths and weaknesses come from differing collection methods, differing criteria for inclusion, different variables that are extracted from the data, and different coding methods for these variables. Due to these limitations, please be aware that these are estimates of the magnitude of the problem and estimates of the descriptive characteristics. This slide shows the number of firefighter fatalities by year since NFPA began collecting this data in 1977. As you can see, the number of fatalities has had a marked decrease over the past 42 years, a 70% reduction from 159 in 1977 to 48 in 2019. It is important to point out that this number is the total number of fatalities, not only due to injuries, but also medical illnesses causes. The number of non-fatal injuries has also experienced a significant reduction, although to a lesser extent. It went from 103,000 in 1981 to 60,000 in 1919, a 41% reduction. Despite these improvements, the numbers still seem high, 48 fatalities and 60,000 non-fatal injuries. To put these numbers in perspective, we need more information. We need denominator information. In other words, how many firefighters are there in the United States? We're lucky that the NFPA also collects this information as part of its fire department profile survey. The number of US firefighters has remained relatively stable over the past 32 years, ranging from just over 1 million to 1.1 million. The number of career firefighters in blue here has grown steadily from about 20% in 98 to almost a third in 2018. The green bars are the number of volunteer firefighters. We now have both a numerator, the number of firefighters injured, and a denominator, the number of firefighters in the United States, so we can calculate an annual injury incidence rate. This incidence rate in red is for the red bar is the number of fatalities. There were 37 fatalities in 1918 for an incidence rate of 3.3 deaths per 100,000 firefighters. The green bar says that there were 57,750 non-fatal injuries for an incidence rate of 5.2 per 100,000 firefighters. This is this, now that we have this data in injury rate form, we can compare it to general private industry using BLS data. If you look at the red bars for career firefighters, they had an incidence rate of 3.5 per 100,000 firefighters. This is the exact same rate that the BLS reported for the private industry in 1918. The green bar shows the non-fatality rate of 5.2 per 100 firefighters in 2018. And this rate was almost double the rate for private industry as reported by the BLS. In addition to NFPA and BLS data, this slide adds the emergency treated injury data. The NICE work database reported an incidence rate of 2.6 per 100 firefighters for the years 2003 to 2014. This rate is about half of what NFPA reported in 2018. This should not be surprising, however, given that NICE data only reports firefighters receiving care in the emergency department, a strong suggestion of more severe injuries. Let's shift gears and discuss the descriptive epi of the fire service and firefighter injuries using characteristics of person, place, and time. For person, this would be demographics, age, gender, and race. This bar shows the age distribution by decades of 4 groups: all firefighters in blue, firefighters suffering a fatal injury in red, non-fatal injury in green, and emergency department treated injuries in gray. Please keep this color scheme in mind because I'll be using it throughout my presentation. A couple things to point out about this. The first is the small but real presence of firefighter under the age of 20. This is due to inclusion of, quote, junior firefighters in many volunteer fire departments. While junior firefighters are typically excluded from fire suppression, they frequently accompany members on emergency runs, and as the graph shows, they can and do get injured. Fortunately, in 2018, at least none of them were fatally injured. Second, the emergency department treated injuries, the gray bars, had a higher proportion in the younger age group, the 20 to 29 and the 30 to 39 age group. Third, the fatalities in the red bars had a higher proportion in the 40 to 49-year-old age group. And finally, the non-fatal injuries, the green bars, were remarkably consistent with the overall age distribution of the entire fire service, the blue bars, remarkably consistent. The green and the blue matched pretty darn well throughout, except when you get to this older age group greater than 60. If you look at gender, the fire service is overwhelmingly male, as shown in the blue bar, which corresponds almost exactly with the injuries: red fatal, green non-fatal, and gray the emergency department treated injuries. The fire service is also a predominantly white workforce. Unfortunately, the injury data sources either did not collect or did not report the race data. This slide shows the NFPA fatality data for 2019 for what they call type of duty, or what the firefighter was doing when the incident occurred. Many or most of the injuries occurred on the fire ground. It's important to point out that firefighters spend less than 5% of their time, or 5% of their shift fighting fires, therefore less than 5% of their time on the fire ground. Therefore, the importance of fireground activities is much higher risk for both death and non-fatal injuries. And this is highlighted in this next slide. This slide has added the proportion, the blue bars, has added the proportion of time at the Cambridge Fire Department and how much time they spend at their various duties. The risk of injury, fatal and non-fatal, on the fire ground is much greater than any other activity. This slide shows the nature of the fatal injury. Nature refers to the medical process by which the death occurred, often referred to as the cause of death on the death certificate. The vast majority of injuries, both fatal and non-fatal, occurred due to internal trauma or crush injuries. For the non-fatal injuries, trauma or crushing injuries refer to strains, sprains, dislocation, fractures, bruises, and other wounds. This pie chart shows the cause of the injury. The cause refers to the action, lack of action, or circumstances that directly resulted in the injury. For fatal injuries, the most common cause in 2019 were rapid fire progression, followed by struck by a motor vehicle or an object, followed by motor vehicle crashes, and then falls. The majority of non-fatal injuries occurred due to overexertion and strain, followed by slip, trip, jump, and fall, and then exposures to both products of combustion or chemicals. Finally, looking at the issue of time. The next two slides are for the U.S. Fire Administration and FIRST data set for fireground injuries from 2015 to 17. The bars are the percentage of fires with an injury by month. The red line is the percentage of all fires by month. In July and August, the higher rate of injuries per number of fires is represented as the bars being above the red line. This slide has the same format, but the x-axis is the hour of the day, not month of the year. The bars are percentage of the fires resulting in injuries by alarm, hour of the alarm. The red line is the percentage of fires by hour of the alarm. A higher percentage of fires with injuries occurred during the night from midnight to 9 a.m., represented here by the blue bars being above the red line. Moving away from the descriptive epidemiology, let's talk about the NIOSH program where I work, the Firefighter Fatality Investigation and Prevention Program. The program began in 1998, largely at the request of the Firefighters Union, the IAFF. The union was concerned that the number of fatalities seemed to be leveled off in the mid-1990s. The leveling off is apparent from this graph that I showed earlier at the beginning of my talk. The union wanted to better understand why the fatalities had leveled off and what they could do to drive this number back down. To accomplish this goal, the NIOSH firefighter program was created to conduct independent, objective investigations of firefighter fatality. The intention was not to find fault or place blame, but rather learn as much as possible from the tragic event. The product of these investigations are individual reports. When grouped together, they form a case series. Each report has a summary that not only provides an incident narrative, but identifies the contributing factors and offers prevention recommendations. We have posted the reports of over 750 investigations on our website. We're very proud of our website and encourage you to explore it. Not only can you access our reports, but you can conduct searches and stratify the results by any number of variables. In my opinion, the information contained in this data set is ripe for a graduate student looking for a research project. Hint, hint. Stephanos Hales at the Harvard School of Public Health has taken advantage of this site, and his residents have published at least 3 peer-reviewed papers using our database. If you review the 400 and plus injury reports and focus on structural fire fatalities, you'll find these 5 contributing factors always seem to be present. The lack of or inadequate scene size up and risk assessment, the communication breakdown, whether it be between dispatch and the incident commander to the task crews, or from the task crews to the incident commander. The lack or poor accountability of crews at the command or the officer level, inadequate command of the incident, and finally, the failure of the department to establish SOPs or failure of firefighters to follow the established SOPs. Looking at our reports from a 9-year period, 2006 to 2014, the most common recommendations offered were looking for were additional training on developing and enforcing the standard operating procedures, improving incident command, more thoughtful fire suppression strategy and tactics, and better communication. Finally, I'd like to present a case we investigated where a Denver firefighter lost his life. The case involved a 46-year-old male career engineer. The engineer is the firefighter who drives the apparatus and operates the panels controlling water coming from the hydrant out to the various hand lines. At 9:30 p.m., the crew responded to a dumpster fire at a commercial structure in the warehouse district, just north and east of the Rhino area. The dumpster was outside the structure, as shown in this photograph, taken a few months earlier. As you can see, the fire extended several feet, probably about 4 feet above the dumpster, damaging the exterior sheet metal wall near this open window. The fire around this window was open, raised concern that the fire had spread to the interior part of the structure. The fire in the dumpster was easily extinguished, but concerns about fire extension, crews then entered the structure and accessed the roof to check for fire extension. All searches were negative. The IC then requested the roof crew estimate the building dimensions. At this time, the engineer stepped onto and fell through a translucent corrugated roof panel, falling 17 feet onto a concrete floor. The engineer suffered several bone fractures and a severed blood vessel. He was transported to a trauma hospital in critical condition. Over a 2-week period, the engineer underwent multiple surgery, and luckily he survived. However, 6 days after discharge, the engineer suffered a massive pulmonary embolus and he died. During daylight conditions, these roof panels can be easily identified as gray rectangles in this photo. However, at night, these panels blend in seamlessly with the corrugated sheet metal roofing. Unrecognized fall hazard associated with walking on translucent corrugated roof panels. It looks low light conditions on the roof, making the translucent roof panels virtually indistinguishable from the sheet metal panels. The engineer was distracted by talking on the radio while walking on the roof. The roof crew did not continuously sound the roof. Sounding is a technique used with a tool with a long handle is used, such as a axe or a 6-foot rubbish hook, to determine whether the surface is stable for one to walk on. We also identified that a previous near incident occurred in the same warehouse district a few years earlier, but was not effectively reported as a learning tool to the entire department, or for that matter, the entire fire service. And finally, translucent roof panels are not required to have the same load bearing. Our recommendation included awareness training regarding the fall hazards associated with roof panels, establishing safe operating procedures for roof operations. This included sounding the roof, not walking or standing on panels or skylights, using ladders for safe exit in low light conditions, or use of the tower bucket when this would be available. We also recommended the department conduct pre-planning building inspections and then enter this information into the computer assisted dispatch, in which when the address is put into the system, warning or hazards about that location are automatically brought up to the responding officer in their apparatus. We also recommended that manufacturers, distributors, and installers of these panels inform the end users of their load-bearing limitations. And finally, we recommended revising the building codes or OSHA regulation requiring roof panels have some of the same safety requirements as skylights, such as these panel guards. In summary, firefighters are exposed to numerous hazards. While the traumatic injury rate does not appear elevated, the non-injury rate is almost double that of the US private industry. The risk of injury, fatal or non-fatal, is much greater on the fire ground and during fire suppression than other on-duty activities. At structure fires, we consistently find five factors that have contributed to fatal injuries. While we like to attribute the falling injury rate over the past 20 years to our program, additional study is needed to assess the degree to which the NIOSH firefighter program has contributed. And with that, I will end, and here are the citations I have for the data sources I mentioned.
Great. Thanks so much, Dr. Hales. That was awesome. I'm sure everybody will be interested in using those citations in the future. They're quite useful. So let me share my screen here. Okay. There we go. Okay. So, and as fate would have it, I happen to work with the department from which the case that Dr. Hales just presented came from. So using my more to practice heavy job than research heavy, I'm going to kind of have a continuing story of what happened after that case. And then we'll talk about some different perspectives in terms of how to use this data to every day to try to prevent injuries from happening in the first place. So just to go through what I do, I spend about a day a week acting as the department physician for Denver Fire. As Emmy mentioned earlier, I'm the division head for occupational medicine at Denver Health, which is a public safety net hospital that works very closely with the city and county of Denver, which makes that relationship a good one. And I'm also on faculty at the Center for Health Work and the Environment at the Colorado School of Public Health. So what I'm looking at here is sort of the current state following that incident in 2015. So we'll talk about some developments in the department on the safety front since that incident happened. And then I'm going to transition into a different NIOSH concept called total worker health, where we try to integrate those safety measures with health promotion measures sort of on the front end. And we'll talk a little bit more about exactly what that means. So since that particular case in 2015, the good news is, most of those recommendations made by Dr. Hales and by NIOSH were taken very seriously and have been translated into new initiatives and a changing culture, which is probably one of the most important things. After the incident, a roof operations training series was created and was administered to the entire department. Department members who are working in operations do have to repeat an updated roof operations class every 2 to 3 years. So the philosophy behind roof operations is something that is not uncontroversial in the fire community. There's sort of the old school way of thinking about it and the newer way of thinking about it. The newer way is sort of more to minimize actual time spent on the roof because it's such a dangerous situation. And like Dr. Hales mentioned, using buckets when possible, completing tasks from the ground or from the inside the structure when possible. So all of that new thinking and sort of transitioning from one way of thinking to another has been a very big part of the discussion surrounding these roof operations trainings. Incident reports. So Dr. Hales mentioned the NFIRS data. What happened after this incident was a mandatory checkbox was added to the NFIR report that the team on the rig has to fill out after every incident. And it had to be checked off. And what it meant was that everybody on the team was offered the opportunity to report or comment on any kind of safety concern that they had during the call. So it's very call specific, incorporated into the incident report of every call. And a safety committee was formed, including members at all levels of rank who meet quarterly and ad hoc as needed to discuss incidents that happen, whether they're minor, whether they're moderate, whether they're major, whether they're near misses, or whether there's a bad outcome. So also developed on the heels of this incident was the establishment of a new role, the establishment of shift commanders. So prior to this incident, Denver Fire did not have shift commanders. It's basically one person every shift who is a dedicated safety officer and is present at any and all fire scenes with the primary goal of making sure that safety procedures are being followed. They also have the option of pursuing informal post-accident reviews as that safety officer observer. They can also jump into operations when necessary if it's needed, if they need help with decision making, if the situation becomes extremely complex. But largely, their sole reason for being the shift commander is to be a dedicated safety officer, which is a pretty big change and has definitely moved the culture forward. Also, another group was created that can carry out something called a post-incident analysis, which is a much more formal investigation following any kind of accident or injury type situation. Only a division chief and or the fire chief can instigate an investigation like this. And it has a series of very formal steps that must be reported. And 99% of the time, the fire chief shares that investigative report with the membership when it's completed, with the goal of teaching and allowing everybody at every level to learn from the mistakes that may have been made. And of course, all of these things put together, bring about a certain degree of cultural change. The emphasis on safety is very different. There's kind of an old-fashioned attitude of, taking risks is part of the job and it's part of what we accept when we come onto this job. Having said that, accepting safety as a daily routine and thinking about it as a normal part of your day is something that they've worked very hard to instill. And it's, by a lot of people's estimations, anecdotally at least, it's a different place than it was 5 years ago, which is encouraging. As far as safety goes, it was good fortune that, I was able to talk to so many people from this department about that incident. And, I think the mental health burden is probably the one that is still hanging around the most. I think in terms of safety procedures, there's a very clear-cut list of things to do and ways to improve it. But that's my segue into our next section, when we ask the question, what other factors must be considered with respect to occupational injuries? So of course there's the safety side, okay? But then there's the side where, who are the people? What are they made of? What kind of health status do they have? The people that we're sending into these situations, okay? So from a philosophical perspective, making sure that people are well equipped and fit and healthy to be able to do these dangerous jobs is a major consideration here, which allows me to bring up another NIOSH program called Total Worker Health. Just a brief description of that. These are policies, programs, and practices that integrate protection from work-related safety and health hazards with promotion of injury and illness prevention efforts to advance worker well-being. So the next couple of sections I'm going to talk about have to do with that health promotion side of things. What are we doing for these workers, these specific workers who work under these incredibly dangerous conditions? How are we best trying to prepare them for that environment? So the first program I'll talk about is the DFD Physical Therapy Program. It was established in 2015, and there are 2 full-time physical therapists who are 100% devoted to the DFD membership. They function in a number of different ways. There's a direct access program where any member could come in at any time for help with a sore joint or something that's bugging them that's not quite an injury yet, but has the potential to become an injury. So a lot can be done on the front end in terms of strengthening and conditioning to improve work performance in that matter. They also see patients for workers' compensation claims through the city and county of Denver when an injury actually happens, whether it's minor, major, whether there was surgery involved. These folks do it all, okay? Some of the other functions that they serve, they administer a functional movement screening program to everybody who comes online. They repeat that functional movement screening periodically, particularly in the setting of an injury, to understand what someone's baseline is and to understand what functional movements need improvement, because as I'm sure some of you are aware, functional movement has a lot to do with how successfully someone can do a strenuous job. And finally, as one might imagine, when you're a physical therapist and you're spending this kind of time with people, you talk to them, you get to know them. And the peer support role of these folks cannot be overstated. I'll touch on this a little bit later, but having physical health as a route to talk through mental health is absolutely key in this population where, addressing mental health is not necessarily a natural choice for a lot of people. But we'll talk a little bit more about that later. More advantages of this program. These 2 are embedded in the department. They're not uniformed, but they are employees of the department and culturally are seen as part of the team, which makes a huge difference in terms of the trust level when they're delivering care. It arose out of a grassroots effort within the Division of Safety and Training, and they eventually partnered with the risk management entity for the city and county of Denver to keep the program funded year after year. It also ended up serving as a template for the Denver Police Department and the Denver Sheriff Department PT programs, which kind of provides the same sorts of services for police officers and sheriffs as well. So some statistics about the program. They had over 2,500 visits in 2019, and they've seen almost all of the membership at this point in one capacity or another. About 36% of their visits, I should say, are workers' compensation claims. About 64% are direct access. They have a really low no-show rate. My understanding from most private PT practices is that the no-show rate can be anywhere up to 15 to 20%. So this is pretty amazing. As far as what they see about 40% upper extremity injuries, 30% back injuries, 24% lower extremity, and 6% neck. 93% of patients on survey explain that they feel very satisfied with the care they received, which is stellar. If you were to equate these visits based on the average cost that the city pays for private PT services in other agencies, The visits total would be about $300,000 a year, and the program cost hovers much lower than that. And this is something that has room to improve even more over the years, simply as they are more and more accepted and as people go to see them more and more often. In terms of outcomes, their average return to work is about 30 days sooner than it is with city employees who get private PT treatment. Their care has resulted in a 50% decrease in median cost per work comp claim over the last 5 years, which is absolutely significant considering how often this population gets injured. And there have been overall decreases in sick time utilization and overtime costs as a result. Some challenges have been encountered along the way. Obviously, these things are never perfectly smooth. Coming up with a solid budget justification, especially at the very beginning of a program, is a difficult thing. And before you have data to support what you're doing, you have to figure out a way to build it, right? So the first couple of years, they had some grant funding, they had some odds and ends from different parts of the department, but it was an exercise in cobbling together resources, which is another lesson we'll talk more about later. Just getting resources for the practice, getting an electronic medical record, getting equipment, every little thing costs money. And when you're just trying to make a program go, a lot of those things ended up being donated, which helped. Thankfully, now they're at a point where when they need something, they can get it, which is great. The quality of the data being collected, whenever you're relying on data to kind of make the case for your program, you want to make sure that you've got good data, and without an extensive information system to collect that, it was a challenge at first. And it's also for the PTs themselves, they had to adapt to a different business model. This was not how a private PT practice is usually run. They actually had the luxury of spending more time with people, but they also had, they have people calling them on the weekends, they have people calling them at night. It's definitely a different boundary than a typical PT model. And finally, getting people at all levels to buy in, was key. There were always champions that were, always involved, but not everybody was 100% on board with this from the beginning. So over the last 5 years, I'm happy to say that this has gone extremely well. And now the attitude is pretty much we can't live without them, which is pretty impressive. So along those same lines, when we talk about, using physical therapy as an injury prevention tool, it kind of begs the question, what about someone's general health? We all know that exercise is good for you. And we know that staying active and staying in shape for a job like this is extremely important. But what about the underlying stuff? Turns out there are many long-term health risks of firefighting, the top ones of which I've listed here. Cardiovascular disease, cancer, behavioral health issues of many different types, and hearing loss. So the wellness program, that's where that comes in, okay? So one of the things that the wellness program advocates for is annual physicals. In this department, it does not happen to be mandatory at the moment, but they are designed for early detection of chronic diseases and their risk factors. The members of DFD have multiple ways they can get this done. About 80 to 85% of the department has Kaiser for insurance, and they have a first responder smart set physical, which has had some good penetration over the years, variable feedback from the members themselves, but it is an option. A couple of years ago, we did a grant-funded firehouse physical pilot program, which was very well received because anytime you can take the service to the members, that's a plus. In 2019, they contracted with an exercise physiology organization to provide health screenings and more in-depth exercise physiology data for their members. And this year, this is me, we're piloting a department physician pilot program to sort of pull all these things together and have a place where they can all live and have someone to oversee it. One of the things we're putting together for next year is sort of an internal beacon program, if you will. We purchased some physiology equipment and are trying to recreate the major portions of the beacon evaluation that people enjoyed in 2019. Unfortunately, the COVID pandemic was not kind to beacon and they are no longer in business. We're also adding the option of a medical consultation onto that using what we call the lifestyle vital signs for chronic disease risk improvement. As far as the physical program is concerned, it was sponsored by a program grant. We had an excellent completion rate, about 92%. We went on site to 6 different firehouses, tried to put 4 or 5 members through every 2 hours, which sometimes it worked great and sometimes it didn't. And then some population characteristics that came out of that were that there are no active smokers in the fire department, which is fantastic, at least not in the population we looked at. Almost 60% had an abnormal audiogram. 60% had elevated systolic blood pressure, 48% had elevated diastolic blood pressure, 20% showed increased risk for obstructive sleep apnea based on risk factors, 18% increased risk for metabolic syndrome based on risk factors, 40% had elevated cholesterol, and 32% were in a borderline level of risk of having a cardiac event from 10 years. So what does this tell us? It tells us we have work to do in terms of the baseline health status of our population. So the department physician program that we're doing this year, we've had to change it quite a bit thanks to the COVID pandemic. We were unable to carry out some of the originally conceived activities in the way we envisioned, but it's an opportunity because this is a group that is often exposed to infectious disease, and dealing with it was something that had to be figured out. So the main functions that I'm serving this year include individual consultations with members. We do some of this virtually, and it was terrible timing because we were just getting started, and it was really gaining popularity in March when COVID hit us. So we're trying to resurrect that part of it as best we can. When required, some advocacy for members with their primary care doctors for follow-up testing is something that we engage in quite frequently. Participating in the COVID response, ensuring testing for the members, ensuring follow-up for people who became ill, and going around and doing firehouse visits to do education about how to stop the spread became a big activity over the summer. We now have a twice-monthly education series called Coffee with Koval that we do virtually and talk about different salient topics in the fire service. Last week, we talked about the COVID vaccine, everybody's favorite. And of course, we have spent lots of time planning for the future of the wellness program and for next year's internal physiology evaluation. And I put building relationships on there simply because it's a new role. And a lot of what I do is I introduce myself to people and say, hey, I'm here, and this is what I'm trying to do. This is just a summary of our ambitions for next year in the exercise physiology program, where only one piece of it, the fitness assessment piece in the middle, is the one that's required for everybody online. But the other pieces are what we're offering in addition to that. The medical evaluation, of course, is strongly recommended, but not mandatory at this point. And then there are additional sort of wellness engagement options, for instance, a lactate threshold test that are meant to, be interesting and kind of draw people in so they can learn more about their own bodies. Now, in terms of implementing these, I'm sure we've all heard of the NFPA 1582 standard and the Wellness Fitness Initiative. I won't go into the weeds about these. I just put here sort of the major categories of information that they advise on. And I guess the point I wanted to make about it is, the standards are fantastic and they're a wonderful reference. I find them a little messy to implement simply because in real life, it's pretty hard to do it to a T. But, without guidance documents like this, it's pretty hard to structure programs like these. So we use these for reference all the time. We stay as true to them as we possibly can. But there's definitely, challenges around implementation, which is my first point on my last slide here, that implementation can be rather messy when you don't know exactly where your resources are coming from next year, and you don't know who's going to be in charge of what, when department leadership changes, which it did this year. It's a lot of kind of 2 steps forward, 1 step back. Oftentimes you're cobbling together resources from different places to make programs like these happen. The relationship building portion of this is absolutely foundational, because when you start to recognize the faces and they're consistent over time, implementation becomes a lot easier. Got to be flexible and got to be ready to compromise, particularly in a municipal environment. Leadership commitment is absolutely crucial. Fortunately, we've had several chiefs in a row here who are very wellness oriented and who have made this a priority. And as I said earlier, the physical health that we're focusing on here is often a conduit to the mental health issues that someone may be experiencing. And so we're really trying to stay conscious of that as we bring people through for the physical pieces of this. And things will go wrong like they did this year. Nobody knew a pandemic was going to hit us, but you know, as long as you've got the relationships and the leadership engaged around you, you can adapt to it and maybe use it as an opportunity. Thanks very much. And please feel free to jump in.
Wonderful. Thank you both so much. We have had a couple of questions coming through, and I really appreciate your sort of focus on the bigger picture too. I think, you know, when we think about certainly the cultures within some of these fields and the traditional kind of maybe culture to run in and put others ahead of oneself, like that can certainly increase risk of injury or say transmissible disease if people don't have the PPE that they should be putting on, but sometimes you know, feel like they can't take the time to put on. So thank you for covering kind of the bigger issues as well as the really important mental health piece. So first question that came through, and this might be for Dr. Hales, was about volunteer firefighters and perhaps also firefighters in training. Are those injuries or illnesses captured in any of the databases?
Great, yeah, thanks for that question. Almost all the data sets group together careers and volunteers. And as I showed the slide from the number of firefighters in the US, currently about 2/3 of all the US firefighters are volunteers and about 1/3 career. Most of the data I presented is grouped together between volunteers and careers, particularly with the individual characteristics. However, I did report for the rates, the incidence rate, only career firefighters. And I did that because we only had BLS data for career firefighters, not for volunteers. So I wanted to compare the career rates versus BLS data. I needed to use career only. If you look at the difference between the rates between careers and volunteers, the careers are a little bit higher. I think looking at fatalities, they were 3.5 per 100,000 firefighters versus 3.2 for volunteers. But you have to remember that career firefighters respond to more emergency incidences than volunteers. And so you have to take that into account. As far as training, absolutely, fatalities and injuries occur during training. I think in 2019, about 10% of the fatalities were due to training and about 12 or 13% on the non-fatal injuries were during training. Training is a big issue, and that's one of the biggest prevention efforts that we can make, because you can control the workplace then. On emergency responses, you can't control the workplace very well.
Thank you. This next question, I think, also relates to the question of who's at risk and who's doing the work. Can either of you speak about the ethical issues of who's put at risk in firefighting, specifically in the context of, say, prison crews in California who were involved in wildfire fighting and were paid, but at very low rates? Any thoughts on that?
I can take a crack at it. We have done investigations of prison firefighters who've lost their life while fighting a fire. I agree with you that they do not have the training that obviously career firefighters or wildland firefighters would have. To my knowledge, they're only used in wildland firefighting, not in structural firefighting. You know, it does raise an ethical issue of how well these inmate firefighters are trained. I know they are trained. I know there is some training. It's just not to the extent of the regular wildland firefighters. Theoretically, they are not supposed to be put in very dangerous situations. I think if you look at many of the inmate firefighters who've lost their life, a lot are due to medical issues and may not have the medical screening and programs that Alyssa's mentioned that are part of the Denver Fire Department that prevent a lot of these medical illnesses from killing firefighters.
Yeah, I would echo that, Dr. Hales, and just say that, you know, I'm 100% sure that these situations lack the sort of the comprehensive approach to preparing that individual both on a personal health front and on the professional training front. I guess my understanding is that it's quite variable, you know, how much training these groups get, and some get a fair amount and some barely get any. So it's a problem. It's a big problem to shove people into this job who don't necessarily really want to be doing it. If you think about it, you know, you gotta want it.
Although I do think that they are. It's not mandatory, but I guess, is it really non-mandatory if you're in prison and you can get outside to fight a fire? So maybe it's not. Yeah, you know, is it really voluntary?
Yeah. Wonderful. Next question, I think I'll send over to Dr. Koval first. Can you provide a top 3 or 3 to 5 things that a department should do to prevent injuries? Where do you start?
Oh, wow. Only 3?
Yeah, I guess you only get 3, yeah.
Sure. So, you know, accepting the reality, you know, not every department can afford a PT program. You know, it's a huge investment and it's a huge lift. Having said that, I think having some kind of strength and conditioning resource, whether it's a strength and conditioning coach or, you know, a relationship that you make with a local fitness facility, some way to consult with people preventively, where you can assess them and figure out sort of what their physical weaknesses might be and what you can do to better prepare that person physically. I think having any kind of resource like that is huge. I'd say second, having an environment where it's okay to admit, you know, and it's okay to talk about the fact that you need to improve certain things. You know, I think we all know that, you know, this environment can be very tough guy heavy, you know, from a mental point of view. So just encouraging people to talk about those things, and whether it's working together or working with a resource, I think acknowledging the need for it is huge. And that has a lot to do with leadership and setting the example. And then finally, you know, again, I'm a preventive medicine physician at heart. So I think paying attention to someone's health in general is always a fantastic starting point for this. I mean, this population has higher rates of everything. And so just having a primary doctor, getting screened the way that the general population gets screened, and even more aggressively in some cases for sort of chronic disease factors. All of those things play into how risky it is for someone to walk into a fire scene. You know, someone walking in with high blood pressure, you're already at higher risk. Somebody walking in who is pre-diabetic, already at higher risk. So sending in the best bodies you can into those situations, I think is of extreme importance.
That's a great point. And to unfortunately, we're running up against the hour. So to close it out, I wanted to ask a question around engineering approaches, because we've been talking about sort of the person and how we prevent injuries in that sense. Earlier in the year, we had a webinar around ergonomic design of spacesuits for astronauts for injury prevention. And I'm curious if you have a wish list of the tools, the equipment that firefighters use right now. What's the first thing we should try to change to make it a healthier job?
Well, I'll take a first crack at this. You know, I started off with saying there's not much we can do from the, substitute, eliminate, and engineer out, but there are some things we can do. And I would point to 2 major things from the NFPA, which has been a huge part of their work, is putting sprinklered structures so that you don't have as many fires to begin with, which is where most of the injuries are occurring. So that would be one thing. The other is fire-safe cigarettes, in which the cigarettes, instead of a lot of the fires, people fall asleep smoking and it lights their bed on fire. The sheets and blankets and things like that. So the fire-safe cigarettes, which have been around for decades, it's just the fire service or the tobacco industry doesn't want to enact that, will prevent thousands of fires because eliminate that. One more thing is that in training, there are 10% of these fatalities occur during training, and we should be able to control that environment better. And it's sort of a macho thing. With the harder you can make your training facility and operations, the tougher you are. And then the last thing I'll say is that I think we have done, the fire service has done a pretty good job. If you look at the trend data over the past 30 to 40 years, that number is going way down. And we've sort of picked up the low hanging fruit there in the sense of, as Dr. Covell mentioned, appropriate screening for medical causes so you don't have the heart attacks on the fire ground. I don't think we have eliminated them, but we've gotten better. In addition, some of the motor vehicle related ones of just firefighters not wearing seatbelts as they respond to firefighters, and then they roll over their tanker and then they die because they get thrown out of the vehicle. So some of those were the low hanging fruit, and you have seen those are responsible for the numbers going down.
Sure. Absolutely. The only thing I think I would add is when it comes to equipment and when it comes to cleaning equipment, one of my firefighter colleagues once said to me that every fire scene is now a hazmat scene. It's almost impossible to distinguish a true hazmat scene from just a structure fire because of the building materials that are used, because of the things that furniture are made of these days. You know, so when I think about that, I think, you know, we probably should be screening all of them as aggressively as we screen the hazmat team. We probably should be treating most equipment with some of the same cleaning and replacement procedures that we do with hazmat equipment. And it's something that the building industry it's changed so much over the last several decades. And I think about those exposures and I think about those chemicals, and that's a whole other Pandora's box of risk.
Oh, well, wonderful. Thank you both so much. You've left us with lots of great food for thought. I hope everybody has a safe holiday season, especially if they're lighting candles in their homes for any reasons. Please make sure you don't start any fires. I hope folks will mark their calendars for January 12th and join us for our next webinar. And thank you again to both of our speakers for joining us. Have a great day.
Thank you.